I will be discussing about tracheostomy and oxygen therapy. The objectives of this presentation is for you to be able to understand and manage patients who had a compromised airway and poor oxygenation. This is an example of a chest x-ray of a patient that has healthy lungs. So you will notice that there is a darkened area here, and that tells you that your patient has good aeration and ventilation. But to patients who have pneumonia, you might see some white spots in here that looks like this. That tells you that there might be pulmonary infiltration around here, or maybe an atelectasis or pneumothorax. Okay, so again, we don't know. But remember, this is what healthy lungs looks like in a chest x-ray. Now, let's talk about compromised airway and poor oxygenation. So when your patient has compromised airway and poor oxygenation, of course, our goal is to address that and to make sure that our patient will be able to survive and that they will have enough oxygen. So as you can see here, this is what the normal human respiratory system looks like. And of course, the external air will go in to the lungs and will have, the CO2, O2 and exchanges will happen in the alveoli, and the CO2 that we don't need will come out in here will come out to the external environment. But of course, if your patient has a compromised airway and poor oxygenation, we have to do some maneuvers to be able to open the airway. So you can do head, tilt, chin lift, and this is how you do it. Okay, you can use towels or pillows to make sure that there is a good angle in here to open up the airway. However, if your patient has, let's say, spinal cord injury, then it would be best to do a jaw thrust maneuver, like what you can see in this image. Now, we're using different equipments when our patient has compromised airway and poor oxygenation. The most commonly used is the bag valve mask. So in here, this is the self-inflating bag. Here's the oxygen reservoir that we need. And this is the pressure gauge valve. And of course, we have to connect this oxygen connector tubing to oxygen flow meter. So you want to make sure that you turn the knob on so that this ball in here will go up. So once it goes up to 15 liters per minute, then you will see that the oxygen reservoir will inflate, and that tells you that it has oxygen inside, and that's when you can use it, like what you can see in this image. So remember that you have to do a C clamp, and you have to put your 3 fingers in here, below the jaw of your patient, and as you can see, this is a head tilt chin lift. Okay, and again, you use this ambo bag, or also known as bag valve mask. Now there are other equipments that we can use, like oropharyngeal airway. It looks like this. So it goes to the oropharynx of your patient, and again, it has different sizes depending on if your patient is a pediatric patient, then you will use the smallest one, or if your patient is an older adult, then you will use the other sizes. Now, if you'll be using laryngeal mass airway, so this is what it looks like. So this goes to up to the larynx of the patient, and of course this will be connected to O2, and this is what it looks like in this image, as you can see. Okay, now you might also see endotracheal tube, and again, it depends on the need of your patient. So in inserting endotracheal tube, remember, this is a healthcare provider's role, and again, as a nurse, you have to be familiar with the equipments. So in here we have the syringe, we have the ET tube, we have the laryngoscope. So what they will do, they will use the laryngoscope to open up the airway, and then again, it has a guide wire, this ET tube, and then they will insert it. And of course, as a nurse, you want to make sure you auscultate bilaterally. okay, to check if it's, you know, in the lungs, and you want to check also the bowel sounds, okay, as the bulb mask, inflate air, and if you hear air movement in the gut, then that means that the ET tube is in the wrong placement. It needs to be adjusted. Okay, so the assessment part, that's what we do as nurses, and we verify with the healthcare provider. Now, post intubation, after your patient had an ET tube, of course, as I mentioned earlier, we auscultate the lung sounds. Your patient will need chest x-ray, and with chest x-ray, this is what the correct ET tube position should look like. So the ET tube should be here. Of course, this is the trachea, and the cuff should be inflated. That's why we have a syringe, and the tube tip should be about 5 centimeter above the carina. Okay, and carina is like where the bifurcation happens in here. So again, it should look like this when you look at the chest x-ray. And of course, don't forget we need ABG, arterial blood gas. Now, if your patient doesn't have any option to have ET tube, and let's say they need long-term oxygen support or ventilatory support, then they will have tracheostomy. So this is what the trach looks like. Okay, tracheostomy means that they created an opening in the trachea. Okay, so as you can see, this is an example of a patient that has trach connected to a T-piece going through this is a BiPAP machine. And of course, again, the O2 support and percentage varies per patient. So with tracheostomy as a nurse, you have to know what you need at bedside. And of course, we need obturator. This is obturator in here. And as you can see in the trach, there is an inner cannula. And this we change every shift or as needed depending on the protocol. And this is the trach. This is what it looks like. Okay. And as you can see, it has a cuff in here that needs to be inflated. Okay. And there are different types of tracheostomy tubes. We have cuff tubes, we have uncuff. Fenestrated. Fenestrated means that there's a hole in the tube, as you can see in here. We need inner cannula. Okay. And what do we need at bedside? We need, of course, an extra trach just in case your patient accidentally remove it or it's accidentally was dislodged. We need either the same size or smaller size, because again, once it's removed accidentally, of course the area will become swollen and the area will become smaller. So that's why we might need a smaller size. You need obturator at bedside. Okay, you want to make sure you have that. And you have tracheostomy care kit, and of course we need this when we're cleaning the trach. Remember, we're using sterile technique, so we need sterile normal saline, we need 4x4 gauze, fenestrated gauze, and inner cannula. It's disposable. Velcro strap so that it goes around the area. Okay, and cotton tip applicator. This is just to clean the area of the stoma. And suction setup, because if your patient's having a lot of secretions, you want to make sure you suction them first, okay, before you perform tracheostomy care. Okay, and again, these are the things that you need at bedside, and what you need at trach care is also what you have here in the trach care kit. Again, this is a sterile procedure. Now, this is what I've mentioned earlier about the gauze, the younger, you also need that to suction any secretions around the trach. Okay. And again, with trach, there are many complications also. Having it for a long time with your patient. So when you are, let's say, ambo bagging, let's say you're using a valve mask, there's a tendency that the tube here will be close to the subcutaneous tissue. So as you inflate air, the air might go to the subcutaneous area and will cause this tension pneumothorax. So that's not good. So you really have to be careful. And this is what it looks like when your patient has it. Okay, they can also have subcutaneous emphysema, wherein again there will be a lot of when you touch this area of the patient, you might feel like rice crisp in there, and that tells you that your patient developed subcutaneous emphysema. And look at the face of the patient. It's very swollen. Now, these are some evidence-based practices that are out there that publish. And as you can see, this one is way back 2013. I know it's a very old evidence-based practice, but still relevant as of today. And that, you want to make sure that you are aware of the new evidence-based practice out there. Now, let's move on to oxygen therapy. So for oxygen therapy, we have different types. We have nasal cannula in here. We have simple face mask. Okay, this is what it looks like. And you don't just memorize the types, but you have to be familiar what it looks like, because when you are in clinical or when you start practicing as a nurse, you want to know what's the difference between simple face mask, partial rebreather, and I'm going to show you the other types of oxygen therapy devices. So here we have partial and non-rebreather. So with partial rebreather mask is, as you can see here, there's like holes in here. Okay, that means that your patient partially rebreathing the air externally. Okay, while non-rebreather, it means that there's a cover in here. That means that your patient is not rebreathing external air. While with high flow nasal cannulas, you can see here, this is high flow and it's connected to this machine. This is what it looks like. Okay, Venturi Mask, this is what it looks like. And remember with Venturi, there's a different, color-coded, device in here. And again, it's color-coded because it represents different percentage of oxygen that you're giving to your patient. And again, you have to make sure you check the healthcare provider's order. We also have here high flow delivery devices. So again, this is a tray color. Okay, and we have a T-piece. Okay, this is a T-piece that will be connected to either ventilator or BiPAP. And remember, for NCLEX purposes, you have to know the home oxygen use. Remember, oxygen is combustible, so you want to make sure you remind your patient to remind their family members or any visitors that they cannot smoke inside the house where you use your oxygen. And you can put like a signage, warning them that oxygen is in use. Now, with oxygen therapy, remember that there are many types because it depends on your patient's condition. So as you can see here, the lowest oxygen component that you can give is via nasal cannula, wherein you're giving 24% oxygen concentration. While for simple face mask, you're giving higher percentage of oxygen, which is about 50%. And partial rebreather to or non-rebreather, you can give up to 90%. And this is usually used for very unstable patients, especially if your patient is in ICU. We commonly use this type of device, and also Venturi Mask, we commonly use this one, which is about 24 to 50% oxygen concentration. We also use 100% high flow nasal cannula to our patient. Now remember that if your patient has chronic respiratory disorders, that remember their baseline partial pressure is 60 millimeter mercury. Like for example, to patients who have COPD, we use this as baseline. So that's why they can only have nasal cannula or no device at all. But to a client that has a normal, lung function, no chronic respiratory disorder, then you have to follow the normal PaO2, which is 80 millimeter mercury and higher. Okay?